Hello, everyone. Hi, I'm Corinne, and I'm actually a member of WOCN, which is the Wound, Ostomy and Continence Nursing chapter of SNA. And today I'm super happy to announce our 3rd anniversary since we started in 2017. It's fantastic to see the registrants, the numbers that has been coming in throughout the last 2 months. We actually have about 400 people showing interest. And I hope that this webinar will give you a lot of sense of awareness of our updates of our nursing activities, especially on today's topic about nursing community, hospitals and nursing homes. So without further ado, I am super pleased to have with us our president of SNA, Singapore Nurses Association, Ms. Samantha Ong. She's a chief nurse who is actually from the Department of Nursing Admin, Institute of Mental Health, Singapore, and she has an executive master in business administration from the University of Buffalo, USA, and a Bachelor of Health Sciences from the University of Sydney. Ms. Samantha is a strong advocate of psychiatry, recovery, and rehabilitation, which I need, and believe in every other person's potential for recovery. She is instrumental in the recovery programs to help patients regain their confidence and develop practical skills to reintegrate into the community. So Samantha places great emphasis on using evidence-based practice and promotes research to her nurses. She has co-authored clinical practice guidelines and research papers and contributed many chapters on the psychiatric nursing books on mental health. Her current appointment is NHG Committee Nursing Member, Council, NHG Productivity and Innovation Committee. So she's very innovative. And she's also an Integrated Cluster Uniform Review Committee for co-chairperson, member of the Nursing Education and Development Advisory Committee for the schools, nursing schools in Singapore, and of course, not to say last advisor for the psychiatry chapter of SNA. So without much further ado, can I please call Ms. Samantha to give us an opening speech? Thank you.
Hi everybody. Thank you, Corinne. I hope you can hear me. If you can, thumbs up. Okay, wonderful. I think in webinar and Zoom, we really every time have to check, right, whether people can hear us or even see us. It is really a beautiful Saturday, and I really want to thank Chu Eng and also thanks Corinne for inviting me to give this opening address. It is really my pleasure. So I'm going to start, okay? So it gives me great pleasure to welcome all of you to this webinar organized by the Wound Ostomy Continence Nurses Chapter. In short, it's WOCNC, okay? So I refer to that because it's quite a mouthful, right? So under the Singapore Nurses Association. So please join me to congratulate them in this joyous occasion as they celebrate their 3rd anniversary today. Wow, 3rd anniversary, wonderful. Congratulations. I hope we have a party, okay, Zoom party later. All right, so today in conjunction with the World Pressure Injury Prevention Day, which falls in the month of November, the WOCN chapters aims to reach out to the community, in particular the community hospitals and the nursing home. They have invited 2 wound nurses from these 2 settings to tell us their experiences on management of the pressure injuries. I hope that we can gain new insight from today's sharing. And I'm very pleased that the WOCN has taken the initiative in the midst of the COVID-19 pandemic to carry out a survey on pressure injury related to personal protective equipment, that's the PPE among nurses. The data that they receive will be very useful in helping to formulate preventive measures for all our nurses. As wound ostomy and continence practices continue to evolve over time, I envisage WOCNC to be the forerunner in evidence-based knowledge and skills through provision of continuing education programs for nurses, healthcare personnel, and carers. So the Wound Ostomy Continence Nurses Chapter was set up in 2017 by a group of like-minded nurses who specialize in wound, ostomy, and continence care. Their objective is to create an awareness of their specialization and presence both locally and internationally. In order to achieve this, they have been committed to organize at least 3 events related to wound, ostomy, and continence yearly. and the events that they have organized in the past were very successful and well received by many nurses. This is evidence close to see that now I have 521, but I'm sure about 450 actually registered for today's event. I'm sure they'll be coming in very soon. Okay, with that, I wish them success in all of their futures activities. Thank you once again for inviting me. Have a good day.
Thank you, Ms. Samantha. Thank you again for gracing the our 3rd anniversary webinar. Deeply appreciate that, and such a warm speech that you gave it to us here. So moving along, we would actually like to call upon our first speaker, which is Ms. Siti Rohaidah Muhammad, who is from Ang Mo Kio Thye Kwan Hospital. Her topic that she'll be telling us is about the Ang Mo Kio Thye Kwan nursing journey in pressure injuries and wound care that starts from 2019 to 2020. The senior staff nurse Rohaidah actually shows her interest in wounds since 2016 and grew fondly after being mentored in developing skincare bundle to prevent incidences of pressure injuries and common skin injuries in Ang Mo Kio, AMKH. She completed the intermediate wound care course organized by St. Luke's Hospital in 2018. Following 6 months of intensive clinical wound mentoring program, she was actually promoted as a wound nurse, where she was instrumental in forming the wound team with 2 other registered nurses. She took over the mantle from her mentor, Stephen Tan, in 2019. She developed the online course on fundamental wound care course for Ang Mo Kio, Thye Kwan, and Thye Kwan group. This year, Siti graduated from the Bachelor of Nursing from Curtin's University under the Community Care Manpower Development Award by the Agency of Integrated Care. She hoped to inspire nurses in the community care sector on promoting skincare to prevent the need for wound care. So with that, she's dedicated to hope, healing, and recovery. So Siti, the floor is yours now, or rather the screen.
Thank you so much. Let me just share my screen. All right, good morning, everyone. So thank you for joining us on this beautiful Saturday morning. I hope everyone is doing well during this period and in best of health. So before I proceed, I would like to thank the WOCN chapter for inviting me to be the speaker for this morning. And it is an honor and privilege to be part of this event. And it is my pleasure to share my journey and experience with everyone. Oh, all right. Warning, please be advised that the following slide contains graphic content that may be disturbing to some viewers. Information shared in this presentation is based on my personal experiences, and content is for learning purposes. Okay, this is not the gruesome images yet. So this is me. Okay, I am the wound nurse in Ang Mo Kio Thye Kwan Hospital. I am running around in a 370 bedded hospital. So this is what I do on a daily basis, and on average, I see around 5 to 6 cases per day, and each dressing takes up around 30 to 45 minutes depending on the complexity of the wound. So this is what I do every day, right? All right, didn't I say that the second slide warned you about the graphic images? These are the pictures that you see. Okay, these are the types of pressure injuries that I nurse or dress, from unstageable of PIs to communicating wounds. I have a fair share of encounters managing. So as you know, as I was doing this dressing for this patient, actually it struck in my mind, at the back of my mind, is that how can we prevent this from occurring? As a nurse from a step-down care, it actually, it feels like it is my duty to provide the best care and allow these patients to heal and return back to the community, and also to give them a proper quality of life. These PIs are causing more pains, and then it impacts their health, their quality of life, and it increases the length of stay in the hospital and also their hospitalization costs. So I think, we got to do something about it. And then these encounters actually creates a deeper interest, and it actually is a driven factor for me to deepen and broaden my knowledge in prevention and management of PIs. So now let's cruise with me as I share my journey in Ang Mo Kio. So back in those days, most of the PIs and complex wounds were referred to the specialized wound action team, or they call themselves the SWAT team lah. So this actually comprises of the...
Hello, everyone. Hi, I'm Corinne, and I'm actually a member of WOCN, which is the Wound, Ostomy and Continence Nursing chapter of SNA. And today I'm super happy to announce our 3rd anniversary since we started in 2017. It's fantastic to see the registrants, the numbers that has been coming in throughout the last 2 months. We actually have about 400 people showing interest. And I hope that this webinar will give you a lot of sense of awareness of our updates of our nursing activities, especially on today's topic about nursing community, hospitals and nursing homes. So without further ado, I am super pleased to have with us our president of SNA, Singapore Nurses Association, Ms. Samantha Ong. She's a chief nurse who is actually from the Department of Nursing Admin, Institute of Mental Health, Singapore, and she has an executive master in business administration from the University of Buffalo, USA, and a Bachelor of Health Sciences from the University of Sydney. Ms. Samantha is a strong advocate of psychiatry, recovery, and rehabilitation, which I need, and believe in every other person's potential for recovery. She is instrumental in the recovery programs to help patients regain their confidence and develop practical skills to reintegrate into the community. So Samantha places great emphasis on using evidence-based practice and promotes research to her nurses. She has co-authored clinical practice guidelines and research papers and contributed many chapters on the psychiatric nursing books on mental health. Her current appointment is NHG Committee Nursing Member Council, NHG Productivity and Innovation Committee. So she's very innovative. And she's also an Integrated Cluster Uniform Review Committee for co-chairperson, member of the Nursing Education and Development Advisory Committee for the schools, nursing schools in Singapore, and of course, not to say last advisor for the psychiatry chapter of SNA. So without much further ado, can I please call Ms. Samantha to give us an opening speech? Thank you.
Hi everybody. Thank you, Corinne. I hope you can hear me. If you can, thumbs up. Okay, wonderful. I think in webinar and Zoom, we really every time have to check, right, whether people can hear us or even see us. It is really a beautiful Saturday, and I really want to thank Chu Eng and also thanks Corinne for inviting me to give this opening address. It is really my pleasure. So I'm going to start, okay? So it gives me great pleasure to welcome all of you to this webinar organized by the Wound Ostomy Continence Nurses Chapter. In short, it's WOCNC, okay? So I refer to that because it's quite a mouthful, right? So under the Singapore Nurses Association. So please join me to congratulate them in this joyous occasion as they celebrate their 3rd anniversary today. Wow, 3rd anniversary, wonderful. Congratulations. I hope we have a party, okay, Zoom party later. All right, so today in conjunction with the World Pressure Injury Prevention Day, which falls in the month of November, the WOCN chapters aims to reach out to the community, in particular the community hospitals and the nursing home. They have invited 2 wound nurses from these 2 settings to tell us their experiences on management of the pressure injuries. I hope that we can gain new insight from today's sharing. And I'm very pleased that the WOCN has taken the initiative in the midst of the COVID-19 pandemic to carry out a survey on pressure injury related to personal protective equipment, that's the PPE among nurses. The data that they receive will be very useful in helping to formulate preventive measures for all our nurses. As wound ostomy and continence practices continue to evolve over time, I envisage WOCNC to be the forerunner in evidence-based knowledge and skills through provision of continuing education programs for nurses, healthcare personnel, and carers. So the Wound Ostomy Continence Nurses Chapter was set up in 2017 by a group of like-minded nurses who specialize in wound, ostomy, and continence care. Their objective is to create an awareness of their specialization and presence both locally and internationally. In order to achieve this, they have been committed to organize at least 3 events related to wound, ostomy, and continence yearly. And the events that they have organized in the past were very successful and well received by many nurses. This is evidence close to see that now I have 521, but I'm sure about 450 actually registered for today's event. I'm sure they'll be coming in very soon. Okay, with that, I wish them success in all of their future activities. Thank you once again for inviting me. Have a good day.
Thank you, Ms. Thank you again for gracing our 3rd anniversary webinar. Deeply appreciate that, and such a warm speech that you gave it to us here. So moving along, we would actually like to call upon our first speaker, which is Ms. Siti Rohaidah Mohammed, who is from Ang Mo Kio Thye Kwan Hospital. Her topic that she'll be telling us is about the Ang Mo Kio Thye Kwan nursing journey in pressure injuries and wound care that starts from 2019 to 2020. The senior staff nurse Rohaidah actually shows her interest in wounds since 2016 and grew fondly after being mentored in developing skincare bundle to prevent incidences of pressure injuries and common skin injuries in Ang Mo Kio, AMKH. She completed the intermediate wound care course organized by St. Luke's Hospital in 2018. Following 6 months of intensive clinical wound mentoring program, she was actually promoted as a wound nurse, where she was instrumental in forming the wound team with 2 other registered nurses. She took over the mantle from her mentor, Stephen Tan, in 2019. She developed the online course on fundamental wound care course for Ang Mo Kio, Thye Kwan, and Thye Kwan group. This year, Siti graduated from the Bachelor of Nursing from Curtin's University under the Community Care Manpower Development Award by the Agency of Integrated Care. She hoped to inspire nurses in the community care sector on promoting skincare to prevent the need for wound care. So with that, she's dedicated to hope, healing, and recovery. So Siti, the floor is yours now, or rather the screen.
Thank you so much. Let me just share my screen. All right, good morning, everyone. So thank you for joining us on this beautiful Saturday morning. I hope everyone is doing well during this period and in best of health. So before I proceed, I would like to thank the WOCN chapter for inviting me to be the speaker for this morning. And it is an honor and privilege to be part of this event. And it is my pleasure to share my journey and experience with everyone. Oh, all right. Warning, please be advised that the following slide contains graphic content that may be disturbing to some viewers. Information shared in this presentation is based on my personal experiences, and content is for learning purposes. Okay, this is not the gruesome images yet. So this is me. Okay, I am the wound nurse in Ang Mo Kio Thye Kwan Hospital. I am running around in a 370 bedded hospital. So this is what I do on a daily basis, and on average, I see around 5 to 6 cases per day, and each dressing takes up around 30 to 45 minutes depending on the complexity of the wound. So this is what I do every day. All right. All right. Didn't I say that the second slide warned you about the graphic images? These are the pictures that you see. Okay, these are the types of pressure injuries that I nurse or dress, from unstageable of PIs to communicating wounds. I have a fair share of encounters managing. So as you know, as I was doing this dressing for this patient, actually it struck in my mind, at the back of my mind, is that how can we prevent this from occurring? As a nurse from a step-down care, it actually, it feels like it is my duty to provide the best care and allow these patients to heal and return back to the community, and also to give them a proper quality of life. These PIs are causing more pains, and then it impacts their health, their quality of life, and it increases the length of stay in the hospital and also their hospitalization costs. So I think, we got to do something about it. And then these encounters actually creates a deeper interest, and it actually is a driven factor for me to deepen and broaden my knowledge in prevention and management of PIs. So now let's cruise with me as I share my journey in Ang Mo Kio. So back in those days, most of the PIs and complex wounds were referred to the specialized wound action team, or they call themselves the SWAT team lah. So this actually comprises of the senior nurse managers as well as the nurse managers. So they were like the resource person for the nurses. So we'd be actually referring them to any complex cases or ask them, oh, what's the best wound product to apply for this patient? And they will give you their best management that they have. So every month, these managers will also track the numbers of PIs that occurs in Ang Mo Kio, as well as those who are admitted with PIs, and then they will do the submissions accordingly lah. So me as a nurse, we do have our care plan intervention as well. And as you can see, I am sharing you with what we have now previously. So the nurses actually perform a gradient scoring and select the care plan for patients. However, as junior nurses then, okay, I admit, psychology was the way. So there was like a mismatch of care plans intervention and scoring. And then most of the nurses select the care plan according to what they think that, based on the intervention itself. We just stick and then we just go on with our life. All right, so in 2016, we created a skincare bundle, so under the guidance of Mr. Steven Tan. So this bundle actually comprehensively depicts the standard of care for patients as part as our nursing commitment to provide excellent care. And then the bundle has 3 components: assessment and evaluation, plan and implementation of care, and rate alert. Prior developing, So prior developing, we need to understand the areas to improve or change related to pressure injury preventions. We have to go through the process of assessment, how frequently we assess the patient. And then with this, we actually incorporate an individualized care plan to create a patient-centered care approach. And we actually pilot this care plan in 110 bedded. And surprisingly, 0%, there were actually 0% incidences of PIs reported, and the patient's skincare were managed professionally. So the nurses' knowledge actually improved as well, and they are able to think critically and implement a comprehensive pressure injury prevention care plan for the patient. So, like I say, let me just break down the bundle for you. So in the assessment section of the bundle, actually we adopted the acronym of BEST short. All right. So as you can see the image on your right, so these are the areas of high pressure injuries. Now we go to the body of the bundle. So the care standard is based on the gradient scoring subscale. So the nurse actually will formulate a care standard for each patient. Thus, each patient will have an individualized care plan for the PI prevention. For example, if I have a patient with a score moisture of 1, I would have to assess whether the patient is on diaper. And then I will go according to the implementation or the scoring based on the scoring itself. So I will just wean off the patient's diaper, and then I will observe any other issues that will arise from the moisture itself. So for the rate alert, we actually will highlight issues to the nursing officers and the medical team. For example, like we know patient has existing or healed pressure injuries, as well as history of PIs, and then whether they have existing maceration or increased risk of maceration. So that's where our team will actually come in to review the patient as well as provide the appropriate care for the patient. So we have skincare bundle to prevent pressure injuries. Then what about our management of PIs? What do we do with the wound? So in 2018, me and along with 2 other seniors actually were selected for the intermediate wound care course conducted by Senduk. So this actually it actually depends our understanding in wound care management, and brought us to the point that, you know, we needed to do something. We need to do changes in the organization. All right. And at that point of time also, my mentor, Mr. Steven Tan, had actually achieved grad cert in wound and ostomy care from Curtin University. And under his guidance and direction, a team was formed to improve standards of care for the skin and the wound. And then we further developed fundamentals of wound care courses, and is supported by our director, Dr. Thye. And the courses were done via e-learning, online learning, as well as classroom teaching. And 90% of the participants passed the test that we provided during the training itself. So now we are in 2020. We are still improving our PI protocol, and actually we created algorithms for the nurses to use as guides to select proper wound care management. And at the same time, we actually incorporate technology in our assessment. Right. So previously, as you can remember, the skincare bundle was a very colorful thing, but in the prevention of PIs, we actually subdivided into different categories, like, you know, the different risks, and then what are the intervention. Sorry, there's a lot of tongue twisting on me today. So it is based on each intervention, then the nurse will have to carry on their care plan. And we also created algorithm for the nurses, so it's easier for them to identify the different stages and what are the intervention that they could do for the patient. You know, these are easier for nurse to see and then to select the appropriate skincare for the patient. So what's for us in the future? You know, wound care is always evolving. So as we are moving forward, we are actually considering in providing wound consultation via telecommunication, and we want to continue in improving our standards in providing wound care and preventions of pressure injury. But although it is a tough journey, as many aware the resources in community sector, the satisfaction is immeasurable. So one of the best experience that I encountered was like a grateful member actually shared her gratitude on air, and it was actually aired in the radio quite recently. And sadly, it is the patient actually passed away, and the family appreciation actually and they appreciate our care. That makes our work more worthwhile. So I do hope that, you know, the nurses from community or settings continue to provide your best care, because, you know, at the end of the day, you receive the best satisfaction in your life that no one can ever give. So I do hope we will proceed on, we will continue giving our best. By that, I thank you so much, and thank you for joining me today.
Thank you, Siti. That was a very interesting talk that you have shared about your journey and with your team and with your ex-mentor. I would like now wish to call upon our second speaker, Ms.Phyllis Tan, currently working at All Saints Home as a head nurse and is involved in the planning and conducting training courses related to wound care. She obtained her postgraduate certificate in clinical nursing with Curtin University and registered with the World Council of Ostomy Therapists. Phyllis has 26 years of working experience in both teaching and clinical care, and is passionate in educating healthcare personnel and caregivers to prevent developing pressure injury and moisture-associated skin dermatitis. Ms. Phyllis will speak on the quality improvement of pressure injuries in nursing home, All Saints Home approach by Ms. Phyllis Tan. Phyllis, please.
Hi, good morning, everybody. Can you all hear me? Corinne, can you give me a thumbs up if you can hear me?
Yeah, loud and
okay,
clear.
Good. All right. Thank you, everybody who joined us on a Saturday morning, zooming in while you can probably sleep in a little later. Right. So before I also want to thank WOCN for allowing me to share what's happening in managing PI and the challenges that we have in a nursing home. So because I'm working in a nursing home whereby we have 4 centers. So All Saints Home, our 4 centers are located at Hougang, Tampines, Yishun, and Jurong. And in a total, we have about 730 beds spread across. So as a head of nurse, I hope you understand that it's really challenging when you're managing the PI across all 4 centers. Okay, so I'll just share with you my objectives for over the next 20 minutes. So I'll discuss with you the data collection and how we analyze the data, and then identify the goals of PI management in All Saints Home, outline the multi-pronged approaches of ASH, this is the one that will be taking more time, and also the ongoing process to reduce incidences of PI at ASH, All Saints Home. Right, so allow me to share with you this data, okay? So if you look at the legend below, you can see that the yellow color is pressure injury occurring in All Saints Home, and the green color is pressure injury occurring outside All Saints Home. Outside All Saints Home, meaning that many are from the restructured hospital, the RHs, but of course, we also understand that the RHs may have pre-existing PI that they receive from the patient at home, right? So in 2018, we can see that the data here is there are more incidences of PI occurring in the nursing home, all right? So interestingly, as you move to 2019 onwards and to 2020, the first, second quarter, right? So you can see that the number is almost on par. That means we are seeing the PI in All Saints Home is reducing, okay? And then the PI that we are capturing from the acute hospital seems to have similar numbers. So for those of us who work in nursing home, we do send our cases out to acute hospital when they have pneumonia, when they have medical conditions, right? So many a times we are capturing these cases whereby when they return to us, we are seeing a number of them develop PI during their hospitalization in the hospitals. Okay, so this table is when I was analyzing the data, the incidence report, okay, and also because every quarterly we have to, all nursing homes, we need to send our data, our clinical indicators to AIC. So in 2018, you can see that the number is 267, inclusive of both ASH as well as outside ASH, right? However, the number of IR incidence report, IR refer to incident report capture, is only a low number of 26. What does that mean? This means that the nurses are not aware that what are the PIs that they need to raise as IR, meaning that most of the time they raise as very bad IR, the PI, whereby stage 3 and more, okay? So the percentage of these PIs are mainly stage 2, and the healing time was not captured. The percentage of DI was also not recognized. This is probably because they think that DTI, may not be aware what is DTI, and they may just report it as redness. Furthermore, there's no break in skin integrity. So this was not captured. And since it's not captured, nobody monitored the healing of DTI. So 2019, I joined All Saints Home in April 2019. So we captured the number, as you can see that it has dropped, okay? But the incident report has increased tremendously, which is what I started off in capturing and intervening the measures based on the incident report. So we wanted to encourage more reporting. So similar, you can see similar patterns whereby most of the PI is stage 2, right? And now our healing time is about 2 to 5 weeks with wound care, etc. It gets to heal within about 5 weeks. As for DTI, there was 16% of them, and the healing time, as you can see from the duration, is about 4 to 10 weeks. And then for 2020 Q1 and Q2, you see similar number with 2019, and then IR have reduced. So earlier on, remember the other slide that we are seeing more cases from the RH side. So the PI is 74% for stage 2. The healing has improved. Stage 2, here the healing has improved, shorter duration, and 18% DTI, and it also we are monitoring to it resolved within 5 weeks. So my goals for PI is reduce the incidences, but without setting the target. How can you set goals without target, the KPI, right? But allow me to share with you is that the purpose is we want to capture the data, what is our baseline? And then I'd rather let the nurse leader to identify their own target. So this will be moving on next year because the first 1.5 years, we are really struggling to manage this PI. So stage 2 PI, we want it to heal within 2 weeks because remember previously in 2018, if these early stages are not well managed, not well monitored, it will definitely evolve to a stage 3 and stage 4. And that will be like what Siti has mentioned, very costly, both in manpower and in terms of the wound care. So we also, DTI do not evolve into become an ash scar. That's why I'm capturing the healing time. For all of us who have seen enough for PI, DTI actually is very serious because DTI can evolve into ash scar at a very short timing if it's not offload properly. So the other things that we want is reduce incidences of recurrence because in nursing home, they are with us for a very long time, many, many years, right? So we want to recognizing these residents and we want to prevent them from re-injury. So I'm going to share with you my approach whereby I have this heading of early detection, close monitoring of wound progress, identify gaps during incident report and interventions. So with these 4 approaches, we hope to can have a faster wound healing and also better quality of life for both residents and of course my nurses, because like what Siti shared, when you do a dressing for a stage 3, it takes a lot of time. Yeah. Okay, so now I move on to early detection. So knowledge and awareness among the nursing leaders and staff are very important. Training, talking to them, whatever approach, we just have to keep creating that awareness. Remember I shared with you, I have 4 centers across Singapore. And because I'm wound trained, so it's very difficult for me to travel or to disseminate. And yet I need to quickly implement measures to bring it down these injuries. So what I do is I send out articles, simple to read articles, knowing our level of nursing aids, EN. So we send out simple articles. I start with the nurse leader first. They have to read this article. They have to raise questions, okay? So and then I start conducting training for my nurse leader. So it's like a trainer. I started with my nurse leader and my clinical instructors. So in nursing home, we rely a lot on our clinical instructor as well because they're very experienced. So we impart this knowledge and skills to them. So the 3 articles that I share with them are stages of PI from the import, skin tear, and IAD. This is very important because many a times the etiology got mixed up and also IAD increases the risk of developing PI. So with that, they now understand to recognize that DTI needs to be reported and needs to be managed aggressively. We also create awareness about mucosal injury. So in nursing home, there are many Cat 4 residents with NGT and also with urinary catheters that if the application of the anchoring is not correct, they develop mucosal injury over the penile region. So wound etiology get confusion. Even previously, whenever I do teaching or sharing in any workshops or etc., I always teach about stage 2 PI, skin tear, and IAD category 2 erosion are commonly get confused and not well differentiated. So this is something that now our staff are very familiar with. So blistering. So stage 2 and DTI have blistering. Okay, so the difference of the blister and how not to confuse with dermatological conditions. So we encourage prompt escalation to the nurse leader through incident report. Then along the way, the etiology, they are not quite sure, but they raise as a PI. We subsequently say that, oh, this is not a PI. You may use S-bar template to email to the nurse leader, CC me including, yeah. So assessment and documentation of any abnormal lesion is a must in NHELP, right? So that includes bruising, skin tear, abrasions, whatever. It has to be documented in the NHELP. And then the counseling template, I created a counseling template. It is not a disciplinary form, right? So it is a counseling whereby I create this opportunity whereby the NL can talk to the staff. Are you aware of the measures? May I know why you didn't escalate fast? You are the one who spotted, why didn't you escalate? So it is not a punitive and it will not affect performance appraisal unless it's a recalcitrant behavior. So this is what I mean by etiology. Tell me the difference, which is a skin tear, which is a PI, or which is IAD or champalang, everything inside, right? So on my right is actually, just allow me to, okay. On my right is a case where I received from the acute hospital. Okay, so in the acute hospital, they stated as an IAD. But most of us who have seen enough of wounds will realize that this is complex. This has a case whereby this is re-injury. That means this resident previously has a PI from All Saints Home. Subsequently, because of the skin textile strength is different, they develop IAD in the acute hospital because of the antibiotics, which is very common. So after that, it has evolved and it has now become a PI, and it's in fact a stage 3. So these are the things that we have to teach our staff. So now I'm going to move on to close monitoring of wound progress. Okay, so in incident report can only be closed until the wound has healed. So the tracking of the PI is a tedious process. So my nurse leader works very hard, and I want to acknowledge their good works. Okay, so for sacral dressing, it's very challenging both in acute hospital, in their own home, or even in nursing home and ComHos. Sacral dressing, because it is always easily contaminated by fecal matters and even urine. Okay, so I will share with you why the nurses need to report to the nurse leader 4 times a day about the sacral dressing. Weekly submission of wound update on every Sunday by 5 p.m. They will have to send in the wound template across all 4 centers to the nurse leader, and I will monitor across all the 4 centers the wounds template. The wounds template include leg ulcer, DFU, and PI, etc. So it's not limited to only PI. And then we'll quickly review and advise by the following 1-2 days. And if need to, I will go down to the centers to review the wounds. So identifying gaps. Okay. Now, identify gaps is a crucial manner. I don't want a culture whereby you're just reporting IR. Yeah, it's good, you know, the capturing of how many PI, but what are you doing to resolve it? So Siti has a very good care bundles. So we are moving on into all the stabilization of these gaps first. Okay. So during the comments by the nurse leader in the incident report, they have to give a lot of information. That means they have to go down and conduct an investigation. So was the turning done? So previously staff are very defensive in the sense that they put that 2 hourly has been done. Now, if 2 hourly has been done, why did the PI occur? So I want to encourage them that it's okay, that we want to know why the frequent turning was not able to perform during this period that's resulted in the PI. So any recent IAD, because we all know that the moisture will trigger and increase the risk of developing PI, right? And also the mobility status. Now, Cat 4, most of us all know that this one high risk, this one's a high risk. So to identify the care bundle, I don't think so it's difficult, okay? However, we have nursing home, we have a lot of category 3 residents who love to sit on the wheelchair and spending long time in the day room. So we have increased number of cases over there. They develop in ischial tuberosity. So I also teach the staff how to recognize that this is due to prolonged sitting, be it on the bed, very high Fowler position, or on the wheelchair. So we teach the staff to recognize this so that the measures can be implemented. So staffing over the last 72 hours, whenever there's a PI occur, I always tell the NL, go and check the roster. Was there short of staff during that period? Sometimes short of staff because they are being called to send cases out for TCU, etc. And then the last occurrence of PI, if applicable, and then other factors such as category 4 residents who are going out for dialysis and TCU. Why? Because for those of us who are from nursing homes, you will understand what I'm trying to share. When a resident that is Cat 4 going for 3 times a week for dialysis, they are away from us, supine position on diapers for at least 6 hours. Supine position for about 6 hours in the diapers, because in dialysis centers, they are unable to change diapers. They are unable to turn because of the reclining chair that they're using. TCU is also important because TCU, the waiting time is at least 2 hours at the clinic, excluding the transporting. So this increases the risk of developing. So if you have a DTI and during this period, definitely it increases the risk of developing into an HCAR. So now that's where I move on in intervention. So you understand all the gaps, then we prescribe the intervention accordingly. This is a bit tedious, allow me to share. Okay, so like what I said, training. I need to disseminate this information at a very fast speed. okay, and to a very big number. So the traditional classroom teaching will not be able to achieve the target in time. So what I do, I like shared previously, disseminate through via email and also using slides. I'll share with you shortly, okay? So NLs to conduct systematic rounding to conduct skin assessment. So my NL spend a lot of time on the ground, okay? They will do random check of, today I want to see the skin, and it's very good because they do the diaper changing with the staff. So they get to spot check and do escalate. Hey, what this one you never inform? You don't inform? So they will pick it up along the clinical rounding. I also do rounding with my NLs. Sometimes I'll just say that follow me the rounds and let's go through some of the cases that I want to see. Wound care. They do not change wound care products without discussion or consulting with me, okay? Because changing wound care products easy, but who's going to monitor? So therefore, after the weekly update that we get to see, we'll discuss whether is there a need to change wound care, okay? Techniques of offloading, we must not undermine this. It's so important, right? So example of the foot and the ears. We're seeing a lot of cases from the RH whereby they develop very bad DTI, even Cat 3 and Cat 4, stage 3 and stage 4 PI. Yeah. So I mentioned earlier anchoring of urinary catheter and NGT. So if there's IR like that, we conduct a mass training across 4 centers, the proper anchoring technique of the NGT to prevent traction. So we did that as well. Pressure relieving devices, I will share with you shortly. Sliding sheet, because some of the Cat 4 residents are heavy, contracted. It's really difficult for my nurses to do a regular turning, okay? Cradle nursing, very traditional, but it's effective. Why do I want to encourage cradle nursing? Is because we tell the staff, check on the residents frequently. But you know how difficult it is? Cat 4 with contractures, putting on pants, removing pants, etc. And they have so many residents to look after. So what I did was I get them to change into gown. We use a draw sheet to cover the residents using clothes packs. It allows ventilation and the diapers will not be sealed. We also inform the family members that why we are doing this in case they say that, hey, why no dignity? Actually, it's well covered. And the family members are happy with this, okay? So you see, if a stage 2 and the IAD, we implement this at a very early stage, the staff make it so easy for them to peekaboo, we can check the skin easily. Okay, so now we also have come to communication, very important. Okay, for those of us who are working in nursing home, do take note of this. Now we send cases out to A&E, we send cases out to dialysis center, outpatient clinic, right? So whenever they have a PI over the sacral, I emphasize a lot on sacral, okay? The staff has to hand over to the ambulance crew on the envelope when they send the memo, right in there. Do not place resident in the supine position while waiting. Okay, so this is highlighted to the A&E staff, etc. We also call the clinic. I also make my NL call the clinic to say that, staff, can I just hand over this case to you? When the resident is here, can you help me to put on a trolley? So many of the staff nurses in the clinic are very thankful because they help us to either up triage, let them see the doctor ASAP, or they actually help my nurses to place in a trolley while waiting. So thanks very much for those of you who are working in the RHs, okay? So we also hand over to other wards when our case transfer out, for example, pneumonia. Our staff will call and say that, staff, this patient has a stage 2 PI, please help us to not worsening the wound when he returned back to us. So there's a handover. Okay, these devices, we introduce head cradle, we'll put a pillow cover, and it reduces the number of years developing PI. So pressure relieving mattress, in nursing homes, we previously all rely on donated, okay, or family purchase their own. We encourage family to purchase their own, but many a times they don't have the financial means, so we do not have enough pressure relieving mattresses. So this year we have increased the number, about 20 units per center, okay, and then we have slide sheet, foot protector, and now we're introducing wedge pillow. So wedge pillow is only for the very high risk, very heavy residents, whereby the pillow are not adequate to support. So that's where we introduce the wedge pillow. Okay, so the next 3 slides are samples of slides that I email to all my centers and with teaching instructions. So this is a sample. So treatment of IAD, I introduce them simple things like that. Then I'll show them how to, sorry, just wait. Okay. something. Okay. Let me go on to the next slide. Sorry. Okay. Just technical glitch. I'm sorry. Okay. Still cannot click. Yeah. Okay, so this is another one instruction. So I teach them that when we are doing clinical round, I saw that this is not done properly. I immediately capture in photos and then we give instruction. So then over here, I give instruction on how should it be done. And also I do a demonstration in the ward with my NL. And after that, I get the staff to demo and then hand over to the next shift. So when we get the staff to teach as well, and I ensure that all who are looking after this resident were able to perform this. This is called clinical training. It works a lot faster than classroom teaching. The second one, during rounding, I saw that a dressing, sacral dressing was so soiled, right? Immediately take photograph, prepare a slide, send out to all the centers, okay? So things like this, can you see that there's the picture below actually has some fecal matter, right? So we get them to recognize it and quickly change the outer dressing to prevent it contamination. Earlier on, I mentioned that the staff will have to send this outer dressing photo 4 times a day to the nurse leader, okay? This is to let the nurse leader advise them that to see, hey, your outside, below is coming off. You need to trim and reinforce so that the dressing can stay on, and this helps with wound healing.
Hi, Ms.Phyllis.
Yeah.
Would you like to slide share for us because we didn't see your screen? Thank you.
Oh, sorry. Oops, didn't know that it was not shared. Okay, so this is the one. Stephen, thanks. Is it better now? Okay, so this was the slide that I mentioned earlier on. The soil dressing that was not changed. So with this, I want to conclude that pressure injury will occur in hospital, nursing homes, and even elderly with functioning decline while they're at home. In fact, I do visit a lot of my friends' parents, elderly parents, to teach the caregiver how to manage sacral dressing. Mainly it's a sacral dressing that has been very difficult for the dressing to adhere to. So in nursing home, in All Saints Home, we have very successful rehabilitation. So there's a certain number of our residents able to go home with a caregiver. So what we did for discharge planning is the staff have to show them pictures of IAD and PI, including DTI, so that they are able to recognize it. And if they identify this, where do they seek help? So it's important for us to do this in a discharge planning. So knowledge of PI is insufficient to reduce occurrence. All of us have understand through my sharing, okay? Adequate staffing and my staff attitude are really important, and they must able to communicate and hand over verbally as well as in help documents, okay? So that the wound like a stage 1 or DTI will not be overlooked. Nurse leader involvement is very important. I hope that today the participants, if you are a nurse leader, be in the RH or in a nursing home, I really hope that you can go on the ground to support the staff. Verbal instruction is not adequate. We must be seen to be doing together with them. Okay, so early escalation and aggressive intervention is really important to prevent wound from deteriorating, and that you can capture a faster healing rate. So all of us know that we have war against DM. So perhaps we should now declare war against pressure injury. And with this, I thank you for your attention. Thank you very much.
Thank you, Ms. Phyllis. That was a very, very interesting and very detailed talk about the wounds and the care and the activation that you are doing in your nursing homes. I shall now open the floor. We have a moderator with us for the question and answer sessions for the 2 speakers, and I really, really encourage everybody to participate. Our moderator for today is Ms. Lim Pui. She's a senior nurse clinician from the Department of National University Hospital Nursing Surgical Cluster. She graduated with a Bachelor of Health Science Nursing from the University of Sydney, obtained her stoma therapy certificate from the Australian Association of Stoma Therapy Nurses in 2004. Currently, she runs the Wound and Stoma Care Nursing Services in NUH. She is a member of the WOCN chapter in Singapore. She received the Nurse Merit Awards in 2012 and the Outstanding Nurse Leader Award in 2017. That's right. Very awesome kind of award she get. So can I invite Phyllis, Siti, and Pui to the stage, please? Participants, you can actually start asking questions in the Q&A, or you can even type in any way that we'll pick up the questions. We will answer those that we can, and if those that we cannot in view of some time, we will actually answer back to you in a post session. Maybe I can start by getting a question to Ms. Siti that is from Ms. Kumari Niran Rai. Her question is, what are some of the challenges you face when piloting the bundle out? Are there resistance from the staff, and how did you overcome the challenges? And with that, I'll pass it to the moderator to take over. Thank you, Pui. Pui, you got to unmute yourself.
Can you hear me?
Yes, yes.
Okay, thank you, Stephen. Thank you everyone for joining us this weekend. So I think we have one question from the ground. I think it's from Kumari. So this question is actually directed to Ms. Siti. So the question actually are, what are some of the challenges you face when piloting the bundle care out? And what are the resistance from the staff? And how can you overcome the challenges? Ms. Siti, would you want to actually share your view on this?
All right. Okay. Thank you, Ms. Kumari, for your question. Okay. Yes, we do face some challenges during piloting the skincare bundle. Firstly, is because we are in a new ward and most of the nurses are quite new and they have different backgrounds, and it's actually quite a challenge because we want them to have mold them so that they know how to use the skincare bundle. Resistance wise, there's not much resistance because we have a mixture of new and old. So it is good that we actually put up a platform for them, that this is actually an open platform for them to learn new things. And then we actually conducted sessions like training sessions, small classes to let them play around, or not play around, actually to look through at the skincare bundle and ask questions. Why are we doing, why are the assessment in such ways? And why are we implementing, and on what base are we taking this bundle from? I hope that answer your question.
Ms. Kumara, is the question answered already? Okay, so we have another question that actually so-called towards Phyllis, Phyllis and Ms. Siti. Don't worry, we will have this together. So he was actually asking, may I ask how you conduct telecommunication to patient and caregiver in handling wound care, and under which category?
Come again. Handle telecommunication.
Yes. Let me see. Okay, how do you conduct telecommunication to patient and caregiver in handling wound care, and under which category? It means, do you all actually conduct telecommunication to patient? And how do you actually teach them to handle their wound care? And under which category do you so-called teach them for pressure injury?
I start first. For nursing home, we currently do not have telemedicine or telecommunication. So once we discharge the resident to their own home, unlike the ComHOS or RH, whereby we do not have a care coordinator to follow up other than the MSW that we call them to find how they're adapting, okay? So if they have encountered problem, they will let the MSW knows, and then we'll probably have to refer to agency, home nursing foundation or whatever to manage the wound. Yeah, so we are different from the RH in that sense. What about Siti? Do you have telemedicine?
Us, we do not have, but I think we were considering it in the future lah. I mean, it's in the process. So apparently for us, when the patient discharged home, we will provide caregiver before they go home, and then we will refer them to HNF or home care team to actually manage the patient at at home lah, or we refer them to the appropriate team to address their issues.
I think from our restructured hospital, we will actually so-called refer to home nursing foundation to actually follow up the patient care. And then if the patient at home, they have other issues, like for example, medical issues, then we will actually refer to our care hub. So they will actually have nurses to go to their home, to do home visits, to monitor their health status. For example, they have COPD, asthma, hypertension. And then if they have concern about, like, for example, bed sore, they will also help to so-called advise the patient, assess the wound condition. So if our care nurses have any difficulty in managing the patient, they also call back to the hospital and then consult the wound care nurses in the hospital. So this is like a so-called hospital to home and then home back to the hospital, what we actually have in our restructured hospital. Okay. Okay, so another interesting question, I think is targeted to Phyllis. How to maintain sacral dressing clean and intact if patient is having loose stool? Does placing a gauze, a piece of gauze at the tail end actually help? I think this is a very interesting question because we all have problem maintaining the sacral dressing intact. So
yes.
anyone, yes.
Oh, I'm very passionate about this.
Yes.
All my nurses know about how I enjoy cleaning and helping changing diapers with them. Okay, so
maybe you'll share with us.
Yeah, there are a few approaches. Number one is find out the root cause of the loose stool first. So that's why I always need my nurse leader to tell them that why is the resident having loose stool? Okay, is it due to antibiotics? Is it due to maybe GE, etc.? So they must target. So sometimes is they continue to give lactulose when already have loose stool, so they don't correlate with IMR. So this is something that now my staff are more aware. Hey, have you looked at IMR? So we target the root cause of the loose stool first, right? Then the next thing, remember I mentioned about cradle nursing. You really want the staff to able to check. There's fecal matter, quickly do the cleaning. So I also teach them how to clean using the hand dexterity. I don't know if you can see my hand, okay? I'm really passionate about this, okay? So you see, many a times, if you don't tell the staff, we think that it's common sense. It is not common, okay? What we do is, you know the wipes? They'll just wipe upwards towards your wound. Of course, that will cause the outside to roll off, etc., right? So I always teach them that use your thumb, and then you do this cleaning, this action, whereby the stool will be moving towards this direction instead of going forward to the urinary meatus or to the sacral wound. So along the way, you do together with them so that they can see how you try to clean, perform perineal care. So that's one, and cradle nursing. You can roll gauze over there, okay, especially the dressing is very, very near to the anus, right? So, but the whole purpose is why you want to roll the gauze there, which I do apply. You want them to sense that if a small amount, it can stop the tsunami. Once you don't check, even you place a gauze, it doesn't serve the purpose. So yes, I do roll this gauze over at the anal region, provided my staff able to check. And lastly, remember the 4 times reporting of outer dressing to my nurse leader. So my nurse leader worked very hard in All Saints Home. Yeah. So I hope they answer the questions.
So I think this is the secret, that you actually check the dressing very, very frequently.
Very close monitoring.
Yeah. Then how about Siti? Do you have any tips that you can share with the audience?
Actually, it's the same tip like Sister Phyllis. We actually identify what is the root cause of the diarrhea, and then we ask like, hey, how come you're still giving lactulose, or is the patient having spurious diarrhea, or is the patient constipated? So if you know the root cause of it, and then when you address it, then you will know that, okay, you will be able to salvage the dressing. So if not, I tell you, it's going to be like every time that the patient pass motion, you have to keep on changing the dressing. And I do agree that sometimes I did apply gauze at near the inner. Yeah.
I think sharing from the restructured hospital, we also will want to know what is the reason for patient having diarrhea, because if that's the root cause not actually addressed, no matter what you actually put, your IED will also get worse. Yeah, and then my nurses also actually put gauze. So the constantly turning and checking the diapers is actually very important. And then cradle nursing, if there's actually a lot of fungi infection or IED. Okay. Okay. Okay.
I think there's a question asking about, does nursing home have restriction with the wound care products? So to answer to Lei Kiao, for nursing home in All Saints, I use Promogran, I use Dermacin, I use Zoflex, I use Aquacel AG+. So residents who cannot afford, or we cannot bill the residents, that is where we appreciate donations. So Lei Kiao, maybe you can consider making a donation to All Saints Home so we can continue our wound care. But seriously, yes, that's where we tap on these donations and to help us with managing wound care. Yes. So we won't stinge on the residents.
I think I have one question to Siti, because I understand that you have only 3 wound care nurses.
We are expanding.
Yeah, okay. So how, because there's only 3 wound care nurses, so how do you actually enable your nurses to actually continue your good care when you're not around, because we are not always there 24 hours? And then how do they actually refer to you? Maybe you can share with us.
Okay, for this kind of cases, right? So, okay, I'll be on the ground every day. So I'll be seeing the patient, or they will refer to me. They will actually drop me a text, or the doctor will refer to me. So they will contact me personally to review the patient. And then once I have actually reviewed the patient, did my assessment, so I will actually put up a treatment plan for them. So I would give them instructions on what are the dressing products to use. And if let's say they do not have the wound product that was brought from restructured hospital, I will give them other alternative, or change them to something that's similar to the product that they have. So then they will be able to continue the care for the patient.
Okay. Thanks, Siti. Because we also have the similar encounter whereby we only have like a few of the wound care nurses. So I think we actually face the same challenges that we have in how to actually ensure our nurses provide the continuity of care, because the ground nurses really need a lot of supervision from us to enable the wound actually heal better. Let's see what are the coming in question that we have. Okay. Okay, I think somebody was actually asking about what is the IAD category 2 that you are using in the nursing home. Do you all use any IAD category, like for example, 1A?
Okay, so for nursing home, I adopt a more simple one. 0 as in skins are normal, 1 as in inflamed erythema without break in skin integrity, and 2 for erosion. So now they no longer use words like excoriation, skin tear, etc. So they know that this, if there's a break in this skin and it has got IAD, they know the right word to use, so that we are all aligned in that. So actually, there's another question asked, any problem do you encounter getting staff to align with you and your PI management? I guess considering for 4 centers, I think it's very fast speed that we're able to reach out to the ground. Okay, so many a times people stop at the RN level, rely heavily on the RN to disseminate the information and EN. But for me, I go straight down to the NA and the HA who are doing diaper changing. So that is the same thing that I will remind the nurse leader. I will even give them a call, hey, this case, have you go and check today or not? So actually across all my 4 centers, I roughly know who are the residents that I will pay attention to, then I will give a thinker, yeah. And the staff also, I allow them to connect with me immediately. So my NA can message me, because if sometimes the NL did not respond in time, especially weekend, I immediately will give advice. So the other day at night, there was they need help for a more venous ulcer. So they called me and we do video call. I know you may consider about PDPA. I explained that later. And I immediately show them step by step how to perform the care. Yeah. So with nursing home, we talk about PDPA, etc. When the resident come in, the family have to sign a consent that we capture a lot of photos for wound care. Mainly is to communicate to the RH among our health team, and it's also for learning purpose. So we don't face any issue. But we do not send photos to the NOK who frequently ask to be sent to their handphone. We do not. Yeah. So are we looking at technology to capture that? It's good to have, but let's be more practical when it comes to nursing home. Those of us who have all the technology of capturing photo, it does take some time to handle this equipment, devices. Yeah.
So there's another question, I think, from one of the attendees. He would like to thank both speakers for your sharing and hard work, because it's a weekend, everybody's here. Okay, so he would like to actually ask for your advice. If family member have financial difficulty, what would be the minimum type of dressing that we can recommend for them with sacral PI after discharge from nursing home to own home? Because I believe the products are actually very expensive. So what is your view on that?
Okay, it really depends on what stages. Okay, so if really cannot afford or very poor, I think it's more of poor prognosis. Okay, so that is where we'll use povidone iodine BP solution, the one without alcohol, and just gauze. You see, the goal is very important. What do you want this wound? Not all PI can heal, right? So we are actually looking at controlled infection. So even my nurses is also so worried. So some of them are end of life due to their chronic medical conditions. So you really don't want to use Aquacel AG Plus on a wound that is not going to heal. So therefore, povidone iodine with gauze is good enough, if that is the case. But again, I say you must see the wound.
So that's why I also agree with Phyllis. We need to see what is the goal of the wound itself, because it is end of life. So we need to actually prioritize what is the most important. Is it the pressure sore or the comfort of the patient?
Yeah.
And then what is available so-called resources in the community. So later on, we will actually share with our participants what are the resources that we have, because we have this wonderful pressure injury hub later to tell you how to actually access on that. We will share with you all later. We will see what other question, what other hot coming question coming in. Okay.
I'm really happy that the participants are asking questions. That means they are all very passionate about PI.
Okay, so there's another participant who actually would want to know what's the challenges when you are teaching and integrating skincare management in all sense nursing home?
Okay, so the classroom teaching sometimes is very enclosed. You think that they pay attention, they are not. But when you are doing clinical teaching, it's more effective. Go and try out and experiment by yourself. Okay, so for us, it is when you teach already, I always get the NL. Have you go around and do random audit, as in interview the staff? Can you tell me what's the latest slide that Sister Phyllis sent out? Can you tell me what is it about? So this kind of thing make the staff to be on alert, that they really know that the communication must be calmed down. So the training is important, and then you see them do a written demo. You do this, so when I have new nursing leader comes in, I also tell them that my IAD and my PI, you must master it within when. Okay. Recently, we also have the SIA cabin crew join us. Also during my training, I teach them IAD and PI. There was an eye-opening for them, and I tell them that because sometimes they do have passengers, long flight with diapers and all those things. So I tell them that actually the risk of this is there and how they can help their passengers. Yeah. So as you can see, I'm just very passionate about PI and IAD. Yeah. So this is how we disseminate. Like I said, the training wise, it really depends on your follow-up. You really need to follow up. You cannot rely on just one session of teaching and thinking that the ground will receive it. No, the follow-up is really important.
How about Siti?
Well, I do agree with Sister Phyllis. So after we actually conducted the training for the nurses, we will actually go down on the ground itself to do like a random check on them. So we will just, I will engage the nurses, and then we will do a we'll do the care together. So as we are turning the patient and we notice something abnormalities to the skin, then we'll ask the patient, so what do you think, this skin tells you? What does it show? And then what is your recommendation? What is your treatment or management for this? So the nurse will be able to actually engage a discussion while doing turning with me. So I think this is one of another way that, instead of having just an indoor or classroom setting, it's best that, we all like go to the ground, randomly check on the nurses to see whether they absorb or understand what they have learned during the class. The application, I would say.
From my point of view, I actually fully agree with Phyllis and Siti, because sometimes when we actually do classroom teaching, so now it's even challenging because we do Zoom teaching now because you only see their face. Okay, so I think the bedside teaching is actually very important. So what we actually do is when we actually review the case, we try to get the RN or the EN to come in to actually assess the wound together with us. So instead of me telling them what is the product that they are using, so we will actually get them to say, hey, so how is the wound? Tell me. So how is the condition of wound if you are the wound care nurse? So I give them empowerment. So what would you actually so-called apply? So now we are the wound care nurse. I'm the staff nurse. So they will actually tell me what to apply. So I think this is a good way to actually prompt them to think. And then if they have any concerns or query, they can actually so-called clear their actually concern. So, but this is actually very, very time consuming because, as you know, restructured hospital, we not only targeted on pressure injury, we have MRSA, we have fall, we have other things. So that's why we actually rely a lot of our nurse leader in the ward to actually help us to monitor. Okay.
Okay, I'm also trying to type the question, but I think I'm quite slow. Can I answer to Sylvia's questions about Sanarin spray, barrier cream, and all those things? So for those of us, I need to explain very clearly. Barrier cream, you must know the ingredient and the product, what is it used for. For example, moisturizing barrier like Kevlon, Sakura, or your Barritex, these are good, and Sanarin are good for when the skin do not have any break, okay, without any break. So once you have IAD, you cannot donate more moisture barrier cream already. You have to switch to something else, right? So that is where you must know your critic cream, or those of you who use Kevlon Advanced, you may have to use that come in. So you must know your product and not just rely on what the vendor say, oh, this one is very good to prevent PI. But when it is moisture, the skin is having a lot of moisture and inflammation, IAD inflammation is a warning sign. So you have to use the right preventive barrier cream on it. Sanarin, so is good when it is for prevention. That means no break, no inflammation. Go ahead and use. Yeah. So for the another one asking about the 4 times a day, how we did it. But we did it. I don't know how to share with you in the sense that, so if my nurse leader are not following closely, okay, I take over. So actually every night, there was 1 or 2 cases that's more challenging for my NL. I take over the monitoring of my sacral dressing across 4 centers. Yes, I take over for my NL. Yeah. So it's okay because we're not calculative as is that, because wound care is really quite, you need time and years to develop. So what I do, I quickly advise the staff, and the staff are fine with it. They don't feel pressurized because they feel that they get the advice immediately. And sacral dressing, try not to shower at night. For those of us who are in nursing home, please don't shower at night because the wound get contaminated and the staff don't change the dressing. So if you have a sacral dressing, please don't let them shower at night, only in the morning, so that the dressing change can be prompt. Yeah.
So do you have any challenges in restricting, strictly carrying out 2-hour turning for your patient and resident? This is one of the questions that the participant was asking.
When I remember how I analyze, okay, you must know that every patient is impossible to have 2-hourly turning. The RHs, okay, you know the challenge as well. So actually I tell my NL, please go and find out their routine diaper changing and turning first. Get the baseline, what is the timing done for this resident. Then only you can advise where did it go wrong. Because there's a period whereby it's 5 hours. You know already, this is the part that you need to identify. So 2 hourly turning is very sacred word in All Saints Home. You don't anyhow use the word 2 hourly. Only those high risk, then you do strictly 2 hourly, 1.5 hourly to peekaboo, to check and quickly clean up and turn the position, right? So I'm very, very careful with my 2 hourly turning. We don't abuse the word sacred. So the rest will be their routine turning, that 3 to 4 hourly generally is good enough, okay? Anything 6 hours, even the wheelchair bound, that is where they develop PI because of the IAD. So I hope I understand the question. Not to use the 2 hourly turning loosely. Only for the high risk.
Moderator.
Sorry, I just want to share on AMOQ side. So we do have a we do have a subacute unit, and then most of the patients are, you know, bed bound, dependent, trachea. So how the nurses actually do this 2 hourly turning? Actually, they do have a time chart for every patient. So when I entered the ward the other day, and I was like quite surprised that, you know, the nurses are actually turning the patient according to the time. And it was like, you know, when I stand in the ward itself, it's like all the patients are in a line. And it's really nice to see, you know, the nurses are actually taking extra care for this patient. And I'm really, really happy, and I'm so proud of them.
Moderator, may I share the experience in terms of earlier on we talked about Zoom training and clinical bedside mentoring.
Of course.
My experience with Siti, because she was my mentee, and how I think the key point here is about in building the interests of your younger nurses. I think we can impart knowledge through many means of training, but the key thing is the attitude. As a trainer, the focus is not, it shouldn't be the wound. It should not only the wound, but also the development of the nurse. So when we, instead of an intimidating way, is what is the wound dressing product you use? I mean, use a very kind term, because a lot of them are interested, but they are fearful to tell you or be openly sharing with you that this thing that they don't know. And sometimes the question can be intimidating, and this actually shut them off. But if you encourage them on their own end, they will go and read up a little bit more. And I think this is what we as WOCN gone through the experience. Our interest is the reason why we went to read deeper, went to take up upgrading courses to find out a little bit more. And I believe that many of our attendees today sign up is because there should be one or two of this inspiring mentor that have actually make us want to learn more today. Yeah.
Okay, then thank you, Stephen, for actually sharing with us. I think it's a good point to actually share, because we also want to actually encourage the nurses to be actually interested in this field. Let me see what are the other questions that the ground would actually post in the website.
One last question, please.
Oh, okay, let me choose an interesting question.
I'll try to
where's my question already? Okay, so how do you actually so-called create a positive culture? Get back to Stephen's question. How do you actually create a positive culture for your nurses to come forward and actually tell you, hey, I have this problem, I have this wound? Because most of the nurses will actually say, hey, if I tell sister, then sister will ask me a lot of questions. Then I have to step back and answer EHOR, all this coming. So how do you actually create a positive culture whereby your junior nurses and your nurses actually come forward and tell you, hey, I really have this problem, sister, can you come over to me?
Well, you're asking me a very challenging question, but I thank you for that. First thing first, I feel that we need to reflect what was the purpose of the question. Majority of the time, our nurses ask questions like that. A lot of time is about firefighting. Wanted to solve the problem, ask you a question for convenience purpose, and that irritates a lot of us because if we are passionate and someone asking us for a quick fix, it just undermine our passion here. So key thing is, however, the question, if it's asked because they are interested to know, I think that is very encouraging for us. I believe our panelists all experience that. So how to promote that? We need to ask the question back. Why do you want to know? And then what is your recommendation? Okay, is a good idea. Is there any other way of doing it? So we should do more facilitation job rather than giving them answer. Otherwise, they will not grow and they will not have interest. And then when we also need to positive reinforce of what their knowledge has. Very good. You understood. Okay, yes, this is a good product. Can you tell me why you choose this over the other product? So this actually builds up a step-by-step kind of confidence in terms of our nurses on the ground. And I think that will slowly build up the culture. The attitude is the most important part of culture building. And the attitude of care is the paramount of nursing.
Anything Phyllis and Siti want to add on before we end the session?
I think a lot of questions asking about IAD. I wish I can share. So perhaps WOCN we need to run another IAD workshop again.
Yeah.
Yes.
Because
I think it's a good idea because I
think they have a lot of cream, but they just don't know when to stop using certain preventive treatment. Yeah. So give us feedback. Do give us feedback because I think we'll be asking for feedback. Please let us know what you would like us to share with you. We will try our best to organize it. Yeah.
Thank you very much, Pui, Phyllis, Siti, and Stephen for giving us a lot of meat into the topic for today. But we are not finished yet, people. Ms. Pui actually has 2 slides to show for the crowd who is here. We have 2 slides actually that's done by the NQC MOH work group and for PI, and this is you can find it in Health Buddy. So I'll let Pui share with you the 2 slides, and at the same time we will follow on with montage. Video montage whereby we will take pictures with everybody who is present. And the other thing is that we will also flash our QR code to gather feedback from all of you who are attending, so that we can move forward and see how else we can be of service to all the nurses who are very, very interested in wound management. So with that, can I ask Pui to share a slide, please?
Okay, the first slide. Okay, so as we are actually part of the pressure injury work group under the National Quality Council Nursing Subcommittee under MOH, we actually developed this pressure injury hub, which is actually can be accessed at the Health Hub. So I've already pinned up the website, and we also have the QR code. So this is a very interesting website whereby it actually tell you about the preventive methods, the staging of pressure ulcer, and what are the treatment, and what are some of the community care service that's actually available. There's also very good e-copy of the resource material such as the pressure injury preventive toolkit, brochure, and poster. And then there's also a video on how the patient and the caregiver actually so-called manage their pressure injury and what is the impact on them. So the next slide. So this is a screenshot of the Health Hub that you can just see on the handphone. So so the pressure injury hub under the subcategory, you can actually see like for example, pressure injuries, what is the impact, and then how do you manage the pressure injury, and what is the and then what is the care journey. So you can actually use this to so-called educate your patient or your residents, or they can actually so-called access this through any of the handphone. So this is actually so-called free to all the public. And then just to highlight that for our group, we the next target will be actually how to actually enhance our public awareness on pressure injury. So we'll actually so-called update you all through your CN, what are the future things coming on the way for our patients or public in that outside. So that's about all for me to share. Pass it back to Corinne.
Thank you. So can we have the QR code up for members and the participants to give us feedback for those interesting questions that we have, and we have many and very challenging questions also, especially on IAD. We will try our best to answer you through our website, or any one of you who are very interested can actually write to any one of us. We have representation in our institution. We can help you with that. But yes, akan datang will definitely tackle another webinar on IAD. Maddie, to you please. So get ready your videos, please, because we are going to do a montage.